Hi, everybody. This is Professor Mohammed Yassin. I am a professor of hematology at Qatar University, and I'm a senior consultant hematologist. And I'm very happy to have you on board today for this presentation, which will be about the effects of tyrosine kinase inhibitors on spermatogenesis, male fertility, and fatherhood in the era of tyrosine kinase inhibitors. And this presentation will be divided into two parts. The first part will be about the effects of tyrosine kinase inhibitors on spermatogenesis and male fertility. And we are going to take one study as an example. And this example is very important because it will show you whether you are decided to do a more comprehensive study or future study, what will be the appropriate methodology. Or if you are caring for patients and the patients want to do how to assess their fertility, this will be a useful guide for you. And this is applied also for the second part of the presentation, which is the fatherhood in the era of tyrosine kinase inhibitors. And we are going to use one study just to tell you what will be the methodology to assess the fatherhood in the era of TKI. So we start with the first topic, which is the effect of tyrosine kinase inhibitor on spermatogenesis, pituitary gonadal axis in males with chronic myeloid leukemia. The objective of this study is, as we know, the introduction of several classes of targeted therapeutics for the treatment of chronic myeloid leukemia raises the question of whether the male fertility is affected, and if it is affected, is it a class effect? So if this is effect related to all tyrosine kinase inhibitors, or if it is not a class effect, is it an individual effect? We mean, does it relate to particular medications? And what is the degree of this effect, if at all, if any, among the different generations of tyrosine kinase inhibitors? And when two drugs are equally effective, the drug with a less toxic effect on fertility may be favorable. Our aim is to evaluate the semen parameters and pituitary gonadal function before and 4 months after starting tyrosine kinase inhibitors, namely dasatinib, nilotinib, and imatinib in patients with chronic myeloid leukemia. What about the design, the setting, and the patients, interventions? We studied the effect of tyrosine kinase inhibitors, first and second generation, imatinib, dasatinib, and nilotinib, prospectively on semen parameters, endocrine function in 20 eugonadal males, patients with chronic myeloid leukemia, and a capacity to ejaculate, aged from 35 to 51 years, and they were receiving either imatinib, dasatinib, nilotinib as upfront therapy. We studied the gonadotrophins, LH, which is luteinizing hormone, and FSH, and testosterone secretions, and evaluated sperm parameters before and after 4 months of using these tyrosine kinase inhibitors. The main outcome measures and results 4 months after starting tyrosine kinase inhibitors, there were a significant decrease in the serum testosterone, LH, and FSH concentrations. The total sperm count, total and rapid progressive sperm motility, and percentage of sperm with a normal morphology decreased significantly versus before treatment. And if you want to see this in number, this table clearly illustrates the effects of tyrosine kinase inhibitors on pituitary gonadal axis and sperm parameters. And to have this table, we have studied multiple parameters. So you have the patient age, you have the LH and FSH and testosterone, and we use these hormones to assess the pituitary gonadal axis. And then when it comes to the sperm, you see we have a different parameters ranging from sperm count, sperm volume, total progressive motility, rapid progressive motility, slow progressive motility, and non-progressive motility, and the immotile form and the normal morphology. And this criteria we used the WHO criteria for evaluation of sperms. So there is a criteria which was launched by WHO criteria. If you want to do study and you want to study your patient objectively and to evaluate the sperm, you have to use the WHO criteria. And this table is consistent with the WHO criteria. And you can see the result of before and after was significantly different, and it was of clinical and statistical significance. So what will happen? What happens to the sperm? After 4 months of therapy, the dasatinib effect on sperm count, sperm volume, all sperm mortalities, and percentage of sperm with a normal morphology were significantly less harmful compared to imatinib and nilotinib. And this table is clearly illustrating the 3 groups. So we have the first group, which is the group of imatinib. The second is dasatinib. The third is nilotinib. We have the patient age, LH and FSH and testosterone on the left side. We have the WHO criteria for evaluation of the sperm, which we just mentioned it, ranging from the sperm count, volume, and the degrees of mortalities and the morphology of the sperm. We have evaluated all of these, and we have checked the before and after. And as you see, the p-value is of statistical significance. So there was a significant correlations were found between the serum testosterone concentration and semen parameters before and after tyrosine kinase inhibitor therapy. And you can see this reflected by the p-value and correlation coefficient, or the R. And you can see the different R's and the p-value and their significance. After TKI therapies, LH were correlated significantly with testosterone concentration, and SV and SC respectively. So the conclusion of this study, our study suggested that a patient with chronic myeloid leukemia receiving tyrosine kinase inhibitor are associated with a significant decrease of sperm parameters and decreased concentration of serum testosterone, LH, and FSH. This potential toxic effect on spermatogenesis are less prominent in patients treated with dasatinib compared to imatinib and nilotinib. The mechanism and pathway for these effects need further human and or experimental research. What are the limitations? Up to my knowledge, this is the only comprehensive study for tyrosine kinase inhibitors available in the literature, and the sample size was apparently low, so we don't have a big number of patients, but it gave us a great clue about what to do and what are the directions. There was no data available yet, I mean real-world data, from other tyrosine kinase inhibitors, particularly bosutinib, ponatinib, and asciminib. The third limitation is the current studies in animal models, and human research gives a clue and future directions. It means from the current studies in the animal models and our study in human subject clearly illustrated that tyrosine kinase inhibitors can reduce the pituitary gonadal function, it can reduce the sperm count, and it doesn't cause infertility. It causes a decrease, but it doesn't cause an infertility. And dasatinib is the safest among the first 3 tyrosine kinase inhibitors with regard to the sperm count and the sperm quality. But this is still a single center study, which is represent a very good model, but needs generalization, but needs to be expanded and should not be generalized. It means we can use it as available evidence, but we should not generalize it until this is a definite conclusion, because we need bigger registries, bigger studies to come with a definite conclusion, and we need to include the new tyrosine kinase inhibitors which are currently available in the markets. The other part of this presentation is talking about the impact of tyrosine kinase inhibitors on fatherhood in patients with chronic myeloid leukemia. And also I'm presenting a single institute experience from our center. As you know, following the launch of tyrosine kinase inhibitors for the treatment of chronic myeloid leukemia, establishing its significance to control the disease as evidence multiple studies, such as the population-based study from the Swedish group registry, showed that patients with chronic myeloid leukemia on tyrosine kinase inhibitor, they will have a normal survival compared to the same age population. Consequently, other dimensions have emerged regarding the safety of treatment, particularly the effect of fatherhood. We got so many males when they are diagnosed with chronic myeloid leukemia, they are asking whether what will happen if I got children? Can I pass this disease to my child? And did you see any of your patients who got a children and their children got chronic myeloid leukemia after 5, 6, or 10 or 15 years? So it remains a concern for patients. And also, it's of importance for hematologists treating chronic myeloid leukemia to have a question for this answer. So we came with this study, and we used the real-world data from patients with chronic myeloid leukemia visiting the National Center of Cancer Care and Research in Qatar from 2005 to 2020. And to the best of our knowledge, this is the first study addressing the effect of tyrosine kinase inhibitors on fatherhood in patients with chronic myeloid leukemia. The methodology which we used in this study is a mixed design. So we used the data, we got the data retrospectively, most of the data, because we are using a comprehensive model for data collections. And also we have an electronic chart for patient records, so we can retrieve all the data around the patients. And we used a phone call because there is a particular questions which the patient should answer. The inclusion criteria was male patients diagnosed with chronic myeloid leukemia, whether in the chronic or accelerated phase, age 18 years or older, and actively receiving tyrosine kinase inhibitors, including imatinib, dasatinib, nilotinib, or other tyrosine kinase inhibitors. Patients with no known issues with regard to fertility is intact, will be included in the study. Patients who developed fertility issues after the diagnosis of chronic myeloid leukemia and starting tyrosine kinase inhibitors has been evaluated by andrologist, and his evaluation concluded it's a TKI related. So if somebody developed a fertility issue after starting TKI, and the evaluation of andrologist and urologist rule out any other causes where we can attribute this infertility issue to, then this kind of patient can be included in the study. We excluded patients with Philadelphia negative myeloproliferative neoplasm. We excluded patients not fulfilling the inclusion criteria, and those are the patients known to have an infertility before the diagnosis of chronic myeloid leukemia, and patients with infertility after diagnosis of chronic myeloid leukemia, if a clear underlying cause, not TKI related, will be excluded from the study, or if no evaluation was done for infertility and it's not clear whether it's TKI related or not TKI related. Those categories of patients were not included in the study. So whether the fertility is related to an underlying cause or TKI and no proper evaluation by andrologists done, they were excluded from the study. The mother had a documentation by gynecologists for infertility, because we are evaluating a male fertility, but we don't have to forget that it's not a male fertility only. Sometimes the couples doesn't produce children because it's the problem with the other partners, with the female, not with the male. So if the mother has a documented history by a gynecologist for infertility, we are not going to include these couples in the study. Or after examining the abortion, stillbirth, or intrauterine fetal death, and checking the chromosomal analysis, which we do in our center, any mother-related cause, whether endogenous or exogenous, has been also excluded from the study. So we have studied 150 patients. We included and interviewed in our study. 22 patients had concern related to medication safety and possible transmission of the disease. 33 patients had their family completed by the time of diagnosis. 26 patients have met the inclusion criteria with a median age around 44 years Median age at diagnosis was 33.5. All patients were in chronic phase. 42% of these patients were on imatinib, 34% were on nilotinib, and 23% of patients were on dasatinib. The median tyrosine kinase inhibitor exposure period before pregnancy was 3 years. Median age at first conception post-tyrosine kinase inhibitor treatment is 36 months, with a median duration of tyrosine kinase inhibitor treatment around 7 years. Offspring's total numbers was 43. 97% were full term, had a normal delivery, and normal average weight at delivery. No stillbirth, fetal demise, or congenital anomalies were reported. All offsprings had a normal development and growth. Median age of children after chronic myeloid leukemia diagnosis around 7 years. No reports of any CML or related cancer in all offspring, and no report of any type of cancer in all those offspring among the period of follow-up. So this diagram is summarizing our study and illustrating what I just said. And it's important to understand this diagram because in real world data, this is not a clinical trial. This is a real world data, how things are going. And if you see here that 150 patients were reviewed, 27 patients were included in the study, and 123 patients were excluded. So the exclusion is more than the inclusion. And if you dig in the reasons, you will find that 22 did not meet the inclusion criteria or they have exclusion. And what about the others? We have 55 patients decided not to have more children before or after CML diagnosis. And this also something which we have to keep in mind is the patient concern. So why they decided not to have more children? Because 33 patients have completed their families. They said they are satisfied, they have completed their families, they don't like to have any more children. And this is reasonable. The other 22 patients had concern related to disease transmission or medication safety. And I think this is an important, and this is an area which we are currently discussing with our patients. And this is very important also for healthcare practitioners or hematologists, as well as the patient group. From hematologist perspective, we think we need a larger study so that we have a more strong and robust evidence about the safety on the offspring. And from the patient perspective, if the patient expressed such worry, also we have to have an empathy with the patient because this concern, we have data, but this data is still limited, and we cannot tell the patient it's 100% that you cannot have an offspring with the disease. So this is also justified, and people doing a real world data, they should understand that some patients completed their families, some patients still, even though you explain and you tell and you show the data which we have, still they have a concern and they are waiting for larger or bigger data or big data to have a confirmation. So the result, 27 male patients were included in the analysis. All were in chronic phase. The median age of the patient was 45 years, and this is the median. And the median age at diagnosis was 34. All patients were receiving tyrosine kinase inhibitors, 12 with imatinib, 9 with nilotinib, and 6 with dasatinib. The median duration of treatment was 7 years. All patients were compliant and tolerant of tyrosine kinase inhibitors with a regular hematology follow-ups. The median age of this male patient at the time of the first conception was 36-year-old, and the duration of TKI exposure before the first pregnancy was 3 years, and the range from 1 to 9 years. So we just explained the result, and when it comes to conclusion, around 98% of males with chronic myeloid leukemia patients taking imatinib, dasatinib, and nilotinib had their offspring born normally with no delivery complications noted. All had no congenital anomalies and had normal growth and development, and no chronic myeloid leukemia related concerns were diagnosed. Further studies with a large sample size are required to shed the light on tyrosine kinase inhibitors outcome on fatherhood in chronic myeloid leukemia patients. And I hope with the help of International CML Foundation, we can kickstart this study this year or early next year, because I believe this is an important area of health. Nonetheless, a call for attention for better education to patients starting on tyrosine kinase inhibitor, on TKIs, addressing the possible psychological fear or concern of having an unsatisfactory effect on their fertility, offspring, targeting better acceptance and adherence to treatment. The limitations, as for the previous study, few data were published in the literature with this regard. There is a necessity for multi-center studies, and I am preparing a survey, which I hope that the International CML Foundation can take it forward about the fatherhood, so that we have a better understanding, taking in consideration our previous experience and the importance of the topic. No data available yet with regard to other tyrosine kinase inhibitors, including bosutinib, ponatinib, asinib. The current studies in animal models and human research gives clue and future directions and should not be generalized. This is my take-home message, and this is very important slide. And I would like to thank Professor Jane Apperly. When reviewing my presentation, she asked to add this slide. And also, I would like to thank my colleague, Dr. Maria, from the National Cancer Care and Research, for helping in preparing this slide. And I believe this slide is summarizing the whole presentation. So here we put the class, we do the BCR-able tyrosine kinase inhibitors, and we put the different types of medications: imatinib, dasatinib, nilotinib, ponatinib, bosutinib, and asciminib. And then we have added the FDA label, so you can go through different classes of different tyrosine kinase inhibitors, and you see what does the FDA say about these medications. And then in the second row, this is the second row, or the fourth one, sorry, the fourth row, you can see the animal studies, whether we have an animal studies in this particular medication or no. And then in the final row, you can see the availability of literature or human study, whether we have any human study with regard to male fertility or no. So this slide is very comprehensive. It's the take-home message. And currently, for better understanding of this topic to our patients and to hematologists worldwide, we are in the stage of preparing an updated review, which we expect will be published in the coming 3 or 4 months. And we will try to kickstart, with the help of International CML Foundation, an international survey for male fertility, so that we have a more comprehensive data. Again, at the end of this presentation, I would like to thank my wife and family for the continuous support, my colleagues from the National Center for Cancer Care and Research, who are always supporting me, the CML patients and their families, because they are the drivers for our care, for our research, and they are the group of patients for whom we are working for. And particular thanks goes to International CML Foundation, trying to solve the puzzle of CML and trying to provide solutions, comprehensive presentation, and for gathering all this group of fantastic experts to give like an focused presentations of chronic myeloid leukemia. Thank you very much.